The attitude in the United States towards illegal immigrants is becoming increasingly hostile, and in light of recent political developments, the situation is not improving. Illegal immigrants are being identified more frequently and deported from the states with little consideration. One situation that is rarely discussed is medical deportation, also known as medical repatriation. Medical repatriation is when a hospital places a patient on a chartered plane, often while he or she is still unconscious, to a medical destination outside the United States. While this process may sound questionable from an ethical standpoint, there are a multitude of reasons why this is still happening. Currently, there are an estimated 11.7 million illegal immigrants in the United States. 60% of them are uninsured and do not qualify for Medicaid. This population tends to work high-risk jobs that rarely offer healthcare coverage, so their options are limited. Federally qualified health centers serve Medicare, Medicaid, and uninsured patients, but unfortunately these facilities are limited and unable to serve this entire population. It is firmly up to the hospital whether or not they decide to keep an uninsured immigrant or deport him or her to a suspected country of origin. Ultimately, this decision comes down to ethics and finances. In the United States, the average cost of inpatient stay depends on the type of hospital. State and local government hospitals are about $1,878 per day, while nonprofit hospitals cost around $2,289 per day. And private hospitals, they average $1,791 per day. Each year, these prices increase. To put this into perspective, an individual with a respiratory system diagnosis requiring ventilator support for less than 96 hours has an average cost of $57,200, which is only 24.4% of the total hospital cost. In 2012, the aggregate United States hospital cost was $377.5 billion, and hospital stays came to 36.5 million. Medicare individually paid the most in each of these categories, followed by private insurance and Medicaid. The type of stay and age of the individual plays a large role in medical cost, with surgical stays being the highest and individuals 45 to 84 years old representing the highest cost overall. Medical air transport to another country is an expensive undertaking of roughly $50,000 depending on the equipment needed and the distance to the receiving facility. The Emergency Medical Treatment and Labor Act of 1986 requires emergency departments to provide medical examinations regardless of one's citizenship, legal status, or ability to pay. It was established to eliminate patient dumping by preventing hospitals from transferring patients without informed consent. While this makes non-consensual medical deportation seem illegal, it only applies to domestic transfers, and this law has no effect on international flights. Hospitals are only required to stabilize emergency medical conditions. After this point, hospitals can refuse service or begin the medical repatriation process. Beyond a formal legal standpoint, there are ethical guidelines established by the American Medical Association's Principles of Medical Ethics. These are the standards medical professionals must follow, acknowledging patients' rights, competent care, and professionalism. In 2001, two principles were added. First, responsibility to the patient is paramount, and second, support access to medical care for all people. Unfortunately, the American Medical Association provides no clarity regarding medical repatriation. The conflict is nicely summed up by Emily Zollner. While violations of legal requirements can result in civil or criminal liability, violations of ethical standards are not violations of a strict code of conduct. Instead, they constitute failures to live up to behavioral ideals. The incentive to comply with ethical standards is a desire to live up to the aspirations of a noble profession, in contrast to a desire to avoid civil or criminal liability. Patient outcomes after medical repatriation are unknown except for individual anecdotes, which are rare. There is no follow-up after the patient is medically discharged, and no reliable data exists on the frequency of medical deportation because hospitals are not legally required to disclose repatriations. Additionally, most patients are deported to hospitals where they are unable to receive the same quality of care that they received in the United States, which contributes to negative health outcomes. On April 9, 2016, a 50-year-old man who had suffered a stroke was admitted to the hospital. The patient entered the United States illegally and had no health insurance. Because no other healthcare facility would accept him, he remained in the hospital for 4 months. Despite recovery and therapy, he was incapable of living on his own. When the hospital could no longer support the patient financially, the case manager proposed sending the man back to Mexico. After contacting the man's family, the case manager made travel arrangements to Mexico. The physician discussed the situation with the man, and he agreed. Although this story emphasizes the consensual transfer of a patient to a facility in Mexico, there are accounts where patients have been medically deported while they were unconscious. These are just some of the reasons why medical repatriation is such a complex issue.